an introduction. So welcome, everybody.
Hi, everyone. I'm Suzanne Gunther, Communications Director at NCEDA, and I'm really delighted to introduce Kate Hill-Johnson of Franciscan Health. Kate oversees and directs community benefit programs for all 14 of Franciscan Health's nonprofit hospitals, which are located in Indiana and Illinois. Frank and I got to participate in a half-day workshop that Kate co-facilitated for Prosperity Indiana members along with hospital community benefits professionals. We really appreciate that she's taken the time to share her expertise with NCEDA members. So before I hand off this webinar to her, I just want to mention that NCEDA will be holding a future webinar on strategies for influencing community benefit folks like Kate.
Okay, well, thank you, Suzanne.
Thank you.
All right, so let's get started with today's webinar. Just a note about how I'm going to go through the webinar today. I'm going to fill the first few minutes of our time together with slides so you can get a feel for community benefit. And then I'm going to take you online to show you some resources and support websites that hopefully will make your jobs a little bit easier when it comes to working with hospitals, as well as looking at community health data. So here I am. My name, like Suzanne said, is Kate Hill-Johnson, and I'm here in Indianapolis where we are dealing with unexpected snow, like lots of you, and I'm not real happy about it. But I'm sure that those of you in the Northeast are feeling the same pain. Please feel free to reach out to me at any time with questions. I'm happy to help and assist in any way I can after this webinar. You can also connect with me on LinkedIn if that is more of your strong suit. So just a note about my background. I've been in public health for my entire career. I recently, before coming to Franciscan, worked at the IU Fairbanks School of Public Health at IUPUI, running the Indiana Public Health Training Center. Before that, I was in a couple of health-related nonprofits, working with youth with cancer issues. I worked with Alzheimer's care, all sorts of things. So this work is really something that's ingrained in me and something that I have a real passion for, and I'm happy to be doing that work on behalf of Franciscan Health. Just a note about our hospital system. Franciscan Health, owned by Franciscan Alliance, is currently at 14 hospitals. We were started about 120 years ago by a group of Franciscan German nuns who were invited into Tippecanoe County to start the first hospital in that area. Tippecanoe County is home of Purdue University, for those of you who might be Boilermaker fans. I bleed red, I'm a Hoosier. But for those of you who know Purdue, that's home of Purdue. And we started the very first hospital in West Central Indiana. And then about 20 years after that hospital opened, the sisters were invited to the Indianapolis area to start a second hospital, which they did in Beech Grove. And that became St. Francis Hospital. So over the years, we've certainly grown and changed and kept up with all sorts of medical innovations. I always put an asterisk by 14 hospitals today because, as you know, the medical landscape is really changing rapidly, and who we are today may not be who we are tomorrow. In fact, we just bought another hospital in northern Indiana, so I could say this is 15 hospitals, but we still have a couple of contracts to sign. All of our hospitals are really in central and northern Indiana, plus in south suburban Chicago. One of the interesting things about our system is because of our Catholic heritage and that of our sisters, and we still have lots of sisters in our system, our hospitals tend to be where no one else wants to run hospitals. So we are in a lot of really low income or kind of challenging communities and take the commitment to serving the most vulnerable very seriously. So when you look at our community benefit programs and where we spend our money and how we do our work here, you're going to see a lot of emphasis on charity care, providing free health care in our communities, and doing the most we can with very limited resources because of our commitment and dedication to charity care. So today I have three major objectives, and of course we can fill in the last segment of our webinar today with any additional questions or objectives you may have. The first thing we're going to do today is look at the community benefit regulation. What is community benefit? What does it mean? How did it happen, and what does it do? Then we're going to spend a bulk of our time looking at the community health needs assessment. Local health departments call this the community health assessment. You may hear it called the CHINA, the CHINA, the CHA. There's lots of different names for it, but it all means the same thing. We're also going to spend just a moment looking at community health improvement plans, which are also called integration strategies or implementation strategies. It goes by a few different names. Our third objective is to explore opportunities to engage hospitals in their community benefit and community health work. So let's start with a quick poll. If you don't mind, head to your screen and let me know. Have you worked with hospitals previously? Have you been able to engage in community benefit, community health, population health, marketing? There's all sorts of different tentacles of what community hospitals do. So I'd love to hear your response. I'll give you just a minute to take that poll, and then we'll show some results. All right, so it looks like we've got about, more coming in. Some of you have had some experiences with hospitals, but a majority of you have not. So we'll hopefully keep this kind of interesting for both groups, and hopefully I can provide you some tips to facilitating that work with hospitals. So let's start by talking about the regulation, and this is something everyone knows, but I always start here because this is the most important piece of what we're going to talk about today. Everything related to community benefit goes back to the fact that clinical care is only 20% of someone's health. You all already know this. You know how important housing is. You know how important the environment is, employment, all of those things. So I'm not going to spend time getting into the social determinants of health. But this is the basis for everything that we do in community benefit as well as in public health in general. So the reason why this regulation of community benefit came up is because of this. Because there was a recognition in the 2000s that we really needed to adjust our health systems in the country. Excuse me. There was finally a recognition that hospitals were providing sick care, and if we ever wanted to break away from that, there needed to be some way that hospitals and health systems started to address all of these other things. Now, with the start of Catholic health care, which was a majority of hospitals in the 1800s, there was already a strong influence in social justice and in community activities. Catholic health saw that as imperative to their work in clinical care. And as we got more and more nonprofit and for-profit hospitals, there was a varying commitment to being a full participant in communities. When the Affordable Care Act was being debated in 2008-2009, there was quite a debate over the tax status of hospitals. One group of people said hospitals should be tax exempt because they provide all sorts of intangible benefits to the communities. They can be anchor institutions. They are often the largest employers in communities. They do a lot that is unaccounted for in their overall budget sheets. Another group said, well, the bottom line is their CEOs seem to make a lot. They're getting a lot of profit and a lot of income, so they look like a business. And the two sides agreed by coming up with the community benefit regulation. And what that community benefit regulation did was take the influence of Catholic Health and their commitment to social justice along with good public health practices and merged them into this regulation. The idea, and I will show you the components of the regulation in just a moment, is to really get hospitals and lots of other groups moving in the same direction so we start to address the 80% of factors that really influence our health. So the regulation has some components to it that are very specific, but underneath each of these requirements, it can be a little vague. So I hope to clear some of this up for you as we continue in the next few minutes. This is a federal regulation that is embedded in the IRS. That's one of the best things about this regulation. It was inspired by the Affordable Care Act and the Patient Privacy Act that was developed in 2009, 2010, but it's not attached to it. So if there ever were to be a repeal of the ACA, it doesn't impact community benefit because it is regulated under the IRS. That sounds kind of crazy, but it's really smart because it makes this regulation extremely stable. It makes it something that can have some pretty significant consequences and keeps hospitals in check on an annual basis. Now, in top of the federal regulation, there are lots and lots of states who have state regulations on community benefit. Some of them mirror the federal government. Some of them are a little stronger. Some of them are a bit weaker. The Hilltop Institute publishes a kind of an annual review of state regulations. I did not include that particular group in my resources at the end of the presentation, but if you ever want to see what the regulations are in your state, just go to the Hilltop Institute and you'll be able to find it fairly quickly. So the regulation starts by saying that all community benefit activities happen really in a 3-year cycle. So every 3 years, the hospital has to produce a community health needs assessment. I'm going to show you the best practices on that in just a moment. It does not, in the community health needs assessment component of the regulation, say exactly what has to be included in that report. I will again show you some of the best practices so you get an idea of what should be included. The second part of the assessment is really the improvement plan or intervention strategies, implementation strategies. Again, you're going to hear that called a few different things. And what that says in the regulation is that once you do the community health needs assessment, you need to figure out what the top needs are in your communities. Once you identify those needs, you need to look at your own capacity to provide in those needs. And you need to pick a few that you are going to dedicate time and energy to for 3 years. So what's nice about this regulation is if you have a specialty hospital, we have one that does nothing but orthopedic care. If I find that in that community what we really need is OBGYN services, I don't have to work on that because my hospital does nothing but orthopedic services. So you can imagine if OBGYN issues are the bigger issue and I just have orthopedists, I can't really do a whole lot. And so the regulation allows that flexibility to say, what's your internal capacity to make a difference in those areas? So you have annual reporting on both the needs assessment and your priorities in your improvement plan that have to be reported on your tax forms I-990s every year. And that data is reviewed regularly by the IRS in consultation with several departments within Health and Human Services and other medical entities within the federal government. The other thing that the regulation says, and you do have to document, are that partnerships are vital. You need to be working with the public health community, healthy coalitions, and other partners within each community so that we can work towards collective impact. It also says that we need to do evaluations, and the outcomes of your priorities should be reported on a regular basis. That doesn't necessarily mean every year we have to report, but it does need to show up in your documents at some point. Generally, hospitals will report their outcomes in the implementation plan, or the CHIP, every time that document is done. So every 3 years, you'll get a look back at what happened the previous 3 years. All items need to be publicly available. And this leads to the accountability and transparency for the public, for the hospital, so that the public can know what the hospital is working on and really hold them accountable to that. When it comes to evaluations and outcomes and internal documents being publicly available, the regulation does say that the needs assessment and implementation plan needs to be on your website. You have to have the last 2 years on your website. You also have to have it available for any walk-ins. So if you walk into a hospital and go to the main desk, they should be able to tell you where to get a physical copy of the assessment and implementation plan. I would say there's probably a lot of hospitals that don't do this very well because volunteers often staff that front desk. But it's just like the regulation in long-term care where their last survey has to be publicly available. You should be able to find it during normal business hours. Someone should be able to answer that question for you. If you fail to do these things, you've got a couple of consequences. The more tolerable circumstance is a daily fine until you correct whatever it is that is in default. And that fine can be up to $50,000 per day. If you fail to go through with those corrective actions, you can lose your nonprofit status. So this is where that IRS piece becomes really important. They're the ones who can levy the fine and take away your tax status. Now, since the regulation came into play in 2011, 2012, depending on your hospital's tax year, there have been about 5 hospitals that have lost their nonprofit status, and all of them have closed because they couldn't handle the tax burden. So if you think about what hospitals have that are tax exempt, you're thinking about property taxes, materials, goods and services. All of those things add up to quite a bit of money. There is some debate on how much money hospitals should be spending on community benefit, and one is that they should spend the amount that their tax exempt status gives them. So if you're exempt $5 million a year, then that's what you should spend. But there has to date been no regulation on how much hospitals have to spend in community benefit activities. So let's talk a little bit more about why this regulation is so important. And this is a slide from the CDC that I'm going to work you through. What's interesting is that this regulation was really written around the same time as local health department accreditation. Some of you are in states where it is required that local health departments become accredited through the Public Health Accreditation Board. It's a little bit of an expensive process. There are several states that allow accreditation to be voluntary. And there's really kind of a debate on what accreditation is going to get you. sounds like we're getting some feedback. Could everyone double check that they're on mute? Thank you. So the public health accreditation, as well as accreditation for federally qualified health centers and other community agencies like United Way, all went through this really great kind of reinvigorating effort at the same time that the community benefit regulation was being developed. And the idea was, let's get everyone on the same page so that there are frequent community health assessments, so that it's more likely that we'll see partnerships and coalitions develop in communities. And so we have this kind of everybody in momentum to get us to better community health outcomes. So you'll see that there was a time when everyone was kind of running in different directions. The federally qualified health centers, community agencies had their process, hospitals had theirs, and it was really kind of messy. It was very siloed. But the CDC has really been able to kind of bring us together around, again, collective impact in communities. So this idea of everyone assessing together, planning together, implementing together, monitoring together, finally gets everyone on the same page. Now, I will say that there probably aren't very many communities where this is happening as intended on this slide. It is a work in progress. Hospitals have only gone through 2 3-year cycles so far. We're preparing for our 3rd cycle. In addition, we have an issue where hospitals are on a 3-year cycle and local health departments are on a 5-year cycle. So that can make it a little difficult to coordinate your efforts. Both regulations say you have to do an assessment at minimum every 3 or 5 years, but it's still pretty difficult to get everyone collaborating and on the same page because of that timing difference. But you're starting to see it in more and more communities. So hopefully this is where we're going. This is what we're trying to get at, where we have an entire community effort around building better outcomes. So let's look at what a needs assessment should really look like and what it should do, since it's really the cornerstone of everything that we do in community benefit, and what local health departments should be doing if they're going through their accreditation and doing needs assessments as well. This is a Kaiser Permanente model. If you are lucky enough to live in a Kaiser community, I'm jealous. They've done some phenomenal work in guiding hospitals in community benefit. And this is one of their models that they use for all of their hospitals and the coalitions in which they work. So let's look at that green bar first. You're going to see in the data collection piece that we're always interested in the demographics, of course, key driver data, and that's really what's happening in a community. What do the social determinants look like? What's the state of employment? What's the net family incomes? How many vehicles are in the community? Is there an issue with transportation? What's access to health care look like? Health outcomes data is going to tell us what the disease states are. How many people have short-term complications due to diabetes? How many people have passed due to heart failure? And then we kind of look at why is that happening? What are those root causes? And we try to link it back into the outcomes and demographics so that we have a really good idea of what's happening in communities. We also need to look at community assets and community input. For the most part, hospitals have all settled on the fact that they do a scan of secondary data, and that's probably going to include hospitalization data. Most hospitals are not going to rely on their own patient data. They're actually going to buy hospitalization data from a hospital association so they can see by zip code or by county or community how many people went to an emergency room due to asthma. And that's not just what's happening in my hospital, but what's happening in my community, regardless of what hospital individuals went to. The second piece that pretty much every hospital will do is some sort of a resident survey. These surveys are all over the board. Some of them are very high quality. Some of them are going to be 5 questions on SurveyMonkey. They're all over the place. So you really, when you're reading a needs assessment, need to evaluate the weight that you put into the survey and the survey results that someone or a hospital might be presenting. There are some really good surveys out there. North Carolina has done a really great job with a statewide survey. In Indiana, we're actually getting ready to launch a survey in 2 weeks that's going out to 60 of 92 counties in Indiana. So you're going to see some real quality ones and then some that you need to be a little wary of. So be sure that you read all of the details related to the survey before you start using it for your own purposes. Now, when you look at the survey and the secondary data, somehow along the way, a lot of hospitals decided that they also needed to do key leader focus groups. I'm not really sure where this came from. I can't find where the roots of this are. It certainly isn't in any guidance. But to do a good community health needs assessment, you don't have to do focus groups. So if you've heard of that there are key leader focus groups, just know that that's not a requirement. I personally don't do them because I want to know what's happening in my communities, not necessarily just what a bank president thinks is happening in his or her community. So at Franciscan, we actually train people who live in low-income housing and in trailer parks to facilitate their own focus groups. So we can really hear from people in communities what's happening and not just assume that bank presidents, business leaders, and such know all of the details. I'm not saying their input isn't important, but it's just not a standard that you have to do that. So in the next box, you're going to see the identification, prioritization, and selection of health needs. So generally to do this, you're going to score the data that you've received. You score your secondary data with a number. You score your survey data. You might score your qualitative data. And you start to come up with a list of what are the most pressing issues in communities. I can tell you after the last round, almost everyone in the country had in substance abuse and behavioral health and obesity. Those always come out. But instead of thinking just obesity, sometimes we have to do some root cause analysis to get into what's really the problem. Is it access? Is it food? Is it physical activity? We have to dig a little bit deeper. So all hospitals, like I said earlier, are able to select for themselves how they score and determine their community health needs. Now, one thing I want to caution here is that a lot of hospitals don't have public health practitioners working in community benefit. Because this is still pretty new to hospitals, you'll have people kind of doing this work who've never done it before. They're just trying to do the job that was handed to them under other duties as assigned. So you really need to kind of read through those assessments before you take it at face value, knowing that you're not sure who put that together and how rigorous their scientific efforts were, because it's really all over the board. I've seen some really small hospitals do a phenomenal job. I've seen a couple of big systems do a terrible job. So just read it and think through the science behind it. Once you have your community health needs prioritized, that's when you start looking at your strategies. And again, you're going to select a few strategies that you're going to kind of sit with and really implement over a 3-year cycle. In my hospitals, I ask for 2 to 4 of those priorities, depending on the size of the hospital, the staffing levels, and what their community needs are. So it's really a small number of priorities. I would be leery of a 500-bed hospital that had 10 priorities because it's pretty hard for a staff of that size to do 10 things really, really well that make a difference in communities. That's not to say they can't, but I would definitely be reading into that and looking at how deep their strategies are. So in this assessment, here's a slide that just kind of tells you what it is that you need to do. You need to define your community. The government allows us to decide what our community is. In some places, it could be the county in which the hospital resides. In other cases, it might be a few zip codes. For us in our South Chicago hospital, we have 8 zip codes that we consider our community for the hospitals that we have. Whereas in a rural county, we consider it the whole county. So you have to look at kind of where are your patients living, what's your market area, and what makes sense in terms of serving a population. So again, that information should be in the needs assessment. You cannot disclude any group of people for convenience. For example, in Indianapolis on the south side, we have a really large Burmese community. They happen to be in one zip code that is next to one of our hospitals. I cannot say my community is everything around that Burmese community. If I claim that I'm serving the zip code next door, the government's going to ask, why didn't you pick the hard community to work in too? So there's definitely some red flags around that. We do have to gather data on our assessments to make sure that we're representing the community. We have to post all of our needs assessments publicly, like we've talked about before. And it has to be, the location of those items needs to be identified in our 990 tax forms. And they have to include those action plans. So what kinds of things count? Like what can we do in community benefit? Well, the categories are kind of vague, but I'm going to take you through a couple of things. First of all, the idea behind community benefit is that we're promoting health and healing in communities that have needs. And that's kind of the bottom line. The government really classifies all of our activities in 4 major categories. Improving access to healthcare services. That's going to include charity care, gap coverage, so if someone has an insurance type that doesn't cover the full amount of their service, we can count that. And that's going to be a majority of where community benefit funds are spent. The percentages that I've noted on this slide are from an IRS audit of 2014 data. So we know across the United States, a majority of community benefit funds are going to charity care and just providing health care to those who need it the most. I can tell you that in my organization, in 2016, we spent about $587 million in community benefit. $300 million of it was in access to healthcare services. The second major category that you'll see is enhancing the health of the community. About 6% of funds are spent here, and that's going to be things like classes or social determinant interventions, access to food and nutrition, housing, those kinds of things. Advancing medical or healthcare knowledge accounts for about 23% of funds and 15% in research. So we're allowed to count towards community benefit a physician residency program. We also run a school of nursing, and that counts. So again, if you take that pot of 100% of community benefit funds, 23% are going to go to internships and placements in schools of nursing and medical residencies, whereas about 15% is going to be in research. This has to be hospital-funded research. It has to be information and research that can contribute to the greater good. So this research has to be disseminated publicly. The rest of the funds then are to relieve or reduce the burden of government or other community efforts. Now, this is a really vague statement that no one will put a dollar value on because it depends on where you live. For example, here in Indiana, we are a home rule state, which means our counties have just as much authority in health-related issues as the state. We're completely decentralized. So our local health departments are all very, very different. And if we have a health department that can't provide immunizations, the hospital can step in and do that because the government can't, and we can count that as community benefit. However, in states that have a really well-functioning government public health program, they might not have that to count. There's also this table, and I'm going to show you a place where you can see these tables that kind of show, again, what those categories are and how money gets spent in community benefit. So if you look at the 3 areas that are in gray, that's all going towards that access to health care line where a majority of funds are spent. You'll see community health improvement services and community benefit operations. So again, that's that 6% of classes and interventions, plus the money it takes for people like me to do their jobs. Health professions education is going to be those schools of nursing, residency programs, internships, research, and then you'll see sometimes we do cash donations and community building. Community building is a debatable category right now. When this regulation was first written, social determinants were not included. And so at the last minute, the regulation was amended to include community building. And at the time, this category really wasn't counted as part of your total impact in communities. So the government didn't see social determinants as being a hospital issue. That has since been amended, but we anticipate that the word community building is going to go away, and it'll just be absorbed into these other categories. So then we have some Catholic Health Association guiding principles. And I'm not going to spend time on this, but you'll see just by looking at it that it's a responsibility to improving the health in communities. The reason why I'm showing you Catholic Health is not because I'm in a Catholic institution, but because the regulation has really been driven by the Catholic Health Association. They are the leading guidance on community benefit. They are the ones who have written the how-to manuals and have really had a history of doing this kind of work. So if you want to know the spirit of what community benefit should be, you can look to the Catholic Health Association. And in the slides, I've given you the link to Catholic Health, so you can go in and read all about the ins and outs of community benefit. So there are a few issues with community benefit. First of all, there's kind of a lack of understanding about public health and the public health system. Hospitals can't be responsible for all of this work themselves. They need strong community partners, and the local health department can't do it alone. But if you know public health and you know the public health system, you know that there are a lot of players that contribute to community health, and we need to bring those individuals together. In a lot of hospitals, especially since this is still a new regulation, the person who is in charge of community benefit was just handed the task. A lot of times you're going to see community benefit in marketing, which the IRS frowns upon, but it happens because you just need someone to do the work. There's also a relatively small allocation of funds in health systems to do this work. You'll see that in 2014, hospitals were spending 3.5% to 10% of their overall operating budget, the mean being 5%. My system tends to be at 10%, but it's because of the volume of charity care that we do. It's a little unstable with health care in terms of reimbursement and how insurance works in our country being at great debate and very, very different from state to state. This can be really unstable. The regulation itself is stable, but how many resources people like me have to do their jobs changes regularly. It doesn't matter if you're in a big system, a small system. if you're Catholic or not. It's just a really tough environment. The other issue is that people in healthcare and people in public health and in community work speak two different languages. They're saying the same things, but they use different words, and that can be a real barrier. There's also some question about how much in charity care hospitals will be providing in the future. Every hospital can write their own policies on charity care. And again, with the changes in insurance types, we don't know what that's going to look like. And let's say I can't count $100 million next year. Does that mean my system's going to give me that much money to do something else in community benefit? Probably not, because every hospital has to right their ship right now, and they have to figure out how to do more with less. There's also a scope of services. When you get into joint ventures, accountable care organizations, all sorts of population health strategies, there's a little bit of debate over how far community benefit goes and where some of these other medical pieces pick up. So for example, we have 16 ACOs, and they're responsible for the overall health of those individuals. If they start working on food access for their patients, that's not community benefit, because community benefit has to benefit the community as a whole. So there's kind of this dancing of trying to align internal health systems and external health systems around communities and who does what work. So how do you figure all this out? I gave you the primer. What do you do now? I'm going to switch over and show you some examples so we can kind of put what I've said into practice. At the end of my slides, I have these same resources, so you'll be able to look them up on your own, except for the few hospitals that I picked out. But hopefully this will give you an idea of how to start your journey into working with community benefit. This is a website called communitybenefitinsight.org. There were a lot of people really excited about this website when it debuted, but I want to caution you a little bit when you use it. When you use this website, you can search any hospital and see what it is they're doing in community benefit, but it's not as forthcoming as you might think. So here we have the homepage, and I'm going to type in Henry Ford Hospital. They do some really neat things in Detroit, and I'm going to search them. So I want to know, what does Henry Ford do in community benefit? Just give it a moment. This website does take a moment to load. Well, we might be coming back to it. I don't want to spend time watching the spinning wheel of death. We'll come back to it. Instead, I'm going to take you over to their website. So here we have Henry Ford. Now, like I told you, the regulation does say that you're supposed to post this information to your website. And if you look at, let's see, this is OSF Healthcare in Illinois, you'll see that right at the bottom of their home screen, you'll find Community Health and Benefits. When you click on that, you'll be able to get right to all of their community benefit information. So here's all of their facilities, and you can click on the PDF and read their summary, or you can look at the full report. So that's a pretty easy one to find. However, over here at Henry Ford, we don't see it at the bottom. And this is where you have to start thinking through where it could be. The next place I always go to try to find someone's community benefit reports is About Us. The About Us section often will contain that, and there you go. Right there under About Us, we have Community Health. So we can see that they have 4 hospitals in Detroit. We can click on those and see exactly what it is they're doing. So they've already posted their 17 to 19 plan, and you'll be able to scroll through and see exactly what they're up to. Again, evaluate the data for yourself. Think through what the survey data means and what other pieces might mean. Now, if we go to Beacon Health, which is also in Indiana, at the top of our state, They are in South Bend, home of Notre Dame, if you like the Fighting Irish. You'll see that it's not down here at the bottom. It's not under About Us. And this is where we just start Googling terms or searching terms. I always start with CHNA because a lot of times when people like me submit their documents for a website, they call it CHNA. So if I just go into CHNA.
Like, yeah, well, it wasn't that big of a deal, but it's like you see, it's still.
Oh, we're getting some feedback.
Mm-hmm.
Here we have publications, and we'll be able to go over to their community benefit reports.
Yes, because, she.
We're hearing someone's conversation. I'm just letting you know so we don't hear anything private. Okay, so our Community Benefit Insights website finally loaded. And one thing that you didn't see is there's a little button that comes on, or a little warning that says this hospital has multiple locations and their information is aggregated. You'll also see that you can only go to 2014 data. So you're not going to see the most recent data, and somehow, and all this information is representative of 4 hospitals. When we went to their website, we saw they have 4. They have 4 separate reports. So you can see in 14 what they did, but that doesn't give you a lot of detail. You can see their breakdown of as a system what they did, and their operating expenses versus their community benefit expenses. When you come down to the bottom, you can look at some other information. These are straight from the tax form. So there's their overall operating budget. They spent 9.2% on community benefit. You can see what they're spending in Medicaid. Cost of means tested government programs, that's going to be everything else if they have expanded Medicaid or other state programs. Here you'll see that, remember that 6% I showed you? This is their 6% or what they have. It's a 0.36% in other activities. So just like that information I showed you on aggregate from 2014, you'll see that a majority of their funds are going to charity care or the cost of health care. They're doing quite a bit in health professions and a little bit in everything else. So you can look through this and see what happened in 14, but it's not going to give you the complete story. If you want to see what a implementation plan looks like, you can hop over to Franciscan Health. Under About Us, you'll find all of my reports, and you can see over time how we've spent some of our community benefit dollars. I'm going to go to Crown Point. And you'll see that there's my needs assessment from 16 and 13 per regulation, and then my implementation plan. So here you can see what is it that we're doing in Crown Point, Indiana. You're going to see a little bit of information. You can see how we ranked our health needs, how we determine our interventional designs. So you'll see all of my models on how we design our implementations. The results from the previous cycle, and then I actually publish our actual action plans. So you can go in and see how we align to Healthy People 2020, if there are other alignments, and exactly what it is we're hoping to achieve in performance and in activities. So that's a pretty typical approach to those implementation plans. Let's see, what else do I have to show you? So again, you can, a lot of times if you see just one report listed, it's going to give you all of the information in one report. Every hospital does it differently. The last thing I want to talk to you about or show you before we open it up for questions is Community Commons. I don't know how many of you have used this site before, but Community Commons is a free website. You do have to do a membership or register as a user, which is very simple. There are lots of places that you might be serving that have a bad needs assessment or no needs assessment at all. And this is a cheat sheet for you. If you go to Maps and Data, you can build a community health needs assessment for pretty much any community that you want. So if I want to run an indicator report, I can pick a state, I can pick a county, and I just view the report. And this is actually going to generate a pretty significant needs assessment. So here you'll see that I can click on all of these data indicators. I can look at health behaviors. I can look at clinical care results. There's quite a bit here, and I will say that not all hospitals know that this exists. So you may need to look at your own data so that you have something more current to talk to hospitals about. Okay, so that's just a brief tour of a couple of different sites that you have at your disposal to really look through and kind of think through when you're looking at needs assessments. And here are those websites for you so that you can, again, look at the Catholic Health Association, you can look at the tax data, you can even build your own assessment so that you know what it is that your communities need. So in summary, we've looked at the regulation, we've looked at the assessment and improvement plan, and we've talked about how to find that data. So at this time, I'd like to open it up for questions and discussion. Feel free to either put it in the chat box or unmute yourself and speak up. Do we have any questions or items for discussion?
Can I ask you a very basic kind of question? This is Hala. I serve on the board of NCEDA. So we want to obviously help you in any way that we can, particularly around the investment in community-related activities or in areas where government is not able due to limited capacity. How can we be of consulting services to an organization like yours?
I think the next webinar is completely on that, but let me give you the short answer. Email me. Tell me you exist. I know that sounds really basic, but that's where it starts. After I gave this presentation at Prosperity, Indiana, I had two people from different communities that I serve come to me who do the kind of work that all of you do and just share with me what they were able to help me with. And it was amazing. It started a great conversation, and I'm already starting to have conversations with them about how we partner to do work in social determinants. You know, like I said, a lot of people who do this work aren't from public health. They just inherited this responsibility. Slowly, we're seeing more and more people from public health going into hospitals who have a better idea, but they might not know who to reach out to. So my number one solution is just let them know you're there. Email them. Ask if they can meet for if you can meet for coffee and just chat. That's the number one piece of advice.
And then can I ask you one more question about follow-up? You said something really interesting around language and how we absolutely speak a very different vernacular in community development from obviously the terms and the language and the approach that healthcare providers use. What are some tips you could give us? And I'm sorry if this is something you'll cover in the next webinar, but what are some tips for the people on this call today that can help us speak the same language as you do and just access the relationship and build the relationship more effectively?
Sure. I think it's a great question. And a lot of it depends on who's doing the community benefit work. I do think because of the move to population health strategies, more and more hospitals are thinking about social determinants. So when you can kind of frame it in what you're doing and what you want to do and what you're looking to achieve in social determinant language, I think that helps a lot. Most of the people in community benefit didn't come from clinical care. They were either in administration, marketing, or public health. So I think, again, just kind of going back to that frame of social determinants, and how we keep people out of the emergency room and out of the hospital, those are key words that every hospital employee wants to hear, because we don't get paid very well when people are in our hospital. We get paid better when they're not in our hospital. When we can keep them healthy, that's where we're going to see increased revenue from our ACOs, our affordable care organizations, and other population health activities. So think about prevention, wellness, and social determinants. Those are the words and the language to really start with.
I'm sorry, can you repeat? I got social determinants. What were the other two?
Prevention and wellness. Prevention of disease and illness, and then wellness in general. How do we get to well communities? How do we get to healthy communities and healthy individuals? When you can kind of take it down to that, prevention, wellness, social determinants, I think that is a great common area that we're all talking about.
Thank you so much. I really appreciate it.
Oh, sure. Other questions, items you'd like to discuss? Any insider secrets that you'd like? I can give you some. Okay. All right. Well, if you have questions or thoughts in between the end of our call and whenever they come to you, always feel free to email me, connect with me on LinkedIn, whatever you'd like to do. I'm happy to help you as much as possible. Oh, I see we do have a question. Are there hospital associations in every state? Yes. And they are usually called something as simple as like the Indiana Hospital Association or the Illinois Hospital Association. Some of the hospital associations are actually taking the lead on community benefit work. I can tell you not in Indiana or Illinois, but in other more progressive states you'll see that. Okay, well, thank you all so much for spending the hour with me, and thank you to our hosts. I appreciate this time with you, and I wish you a lot of luck. Stay with community benefit, people. We mean well. We have a lot on our plates, but we want to get to it, and we desperately do want to work with people like you. So thank you again, and safe travels this weekend, and I hope to meet up with you in the future. Thank you.